Have you ever reached for your seatbelt or tried putting on a jacket or roll over in bed and suddenly realize you just can't move? Like your shoulder will not move at all.
Really distinguishes frozen shoulder from other shoulder conditions is that it's not just pain, it's that the patient literally cannot move their arm, even if they wanted to.
Are there symptoms to look for before it happens, or do you just wake up one day and you can't move your arm? Like, what should people expect?
There are some people that really never come out of it, but even under best case scenarios, you're looking at 2 to 3 years for this to go away on its own.
How is it better or different?
Specific, it's targeted, it's image guided, and it's actually directly treating the cause. And these procedures are safe, they're quick, and they're convenient. The results are shown to be as good or better than surgery.
Hey everybody, welcome back to the OBL and ASC Marketing Blueprint podcast brought to you by Patient Pro Marketing. This is going to be a specific segment geared towards patients. Like, have you ever reached for your seatbelt or tried putting on a jacket or roll over in bed and suddenly realize like you just can't move, like your shoulder will not move at all? Today, we're going to talk about a condition called frozen shoulder or adhesive capsulitis, a condition that can quietly take over your life, leave patients frustrated for months and months, sometimes even years, and it's often misunderstood and undiagnosed or misdiagnosed. We're going to dive into what causes it, what happens, how interventional radiology is changing the treatment options for this. Today, I have Dr. AJ Valenson from Texas Endovascular down in Houston with me, who's going to share about shoulder embolization. Thanks so much, Dr. Valenson, for being here with me today.
It's my pleasure and my privilege. Thank you for having me.
Yeah. Tell us, what's your background and why do you focus on MSK treatments?
Sure. Yeah. So I'm an interventional radiologist. So what this means is basically we perform procedures, but unlike surgeons, our procedures are minimally invasive. So we're not really cutting people open. We're using image guidance to perform procedures. So this involves the use of really advanced equipment and tools, some things that patients are familiar with, like catheters, stents, wires, balloons, things of that nature. And I have a specific focus in vascular interventional radiology. So all the procedures that we focus on involve the vascular system, which pretty much covers almost everything in the body. And we are the perfect field or providers to also treat patients with MSK issues. And so this is kind of a new and exciting branch of our field of MSK interventional radiology. And because it involves treatments of abnormal vessels, we feel that there's no better person than a vascular interventional radiologist to perform these procedures. So that's kind of how I sort of fell into the specific branch of the field. Like a lot of people, not really intentionally necessarily, but it just seemed like a natural extension of the skill sets we already have. And we think it's a really exciting field. There's a big need for it. There's a lot of patients with not a lot of options out there. And so I'm very proud to say that we're able to provide some of these patients a few more options, and some of them are really, really good options for some of these conditions.
Yeah, I want to thank you for explaining what interventional radiologists do. I feel like it's up and coming still, right? Even though IRs have been around for years and years, when you talk to just a normal person on the street, they have no idea what an interventional radiologist is. I had no clue when I first started in this industry either. Just knowing what I've been in the OR, I've seen IRs work. I call you guys like the magicians with wires and catheters because you truly are. Like the places in the body and things you can reach and treat with little point accesses and tiny tools is amazing. You must have really good hand coordination.
I think magician is, I wish I could call myself a magician, not quite. But yeah, interestingly enough, I was reading an article a few years ago that interventional radiology was the least known field in all of medicine. It kind of blew my mind and shocked me. But then I realized that even my own parents didn't really know what I did at the time. My mother thought I was a radiation oncologist treating cancer. And I think my father thought I was just a diagnostic radiologist reading x-rays and things of that nature. But I think at this point, it's had such a profound impact in all of medicine. It's growing at an incredible pace. It's really ahead of the curve. It's constantly pushing the boundaries of what we can do, that I think other doctors are turning to interventional radiologists, and even patients are becoming really aware of it. So I think now, fortunately, I don't think we're probably the least known field in all of medicine. I think the word is getting out about all of the cool things we can do. I myself started on a track where I was going to become a surgeon. It's what I wanted to do. And even during the course of my surgical training, internship, residency, just the exposure to IR, when I realized that they could do a lot of the things that we were doing without cutting people open, I just thought it was so elegant, so ahead of the curve. And I decided that I wanted to make the switch to do something like that I thought was really the future. And now the future is here. A lot of the procedures we're doing are really, really new, and we're able to introduce them even quicker because we're just getting so advanced. And some of it is just pushing the field a little bit further, inventing devices that are maybe a little bit longer, a little bit smaller, a little bit more precise. I wouldn't say we're magicians, but maybe more like MacGyver. We've got
I love it.
a lot of
Yeah.
really cool tricks and tools we can use to get things done in an ingenious way.
Yeah.
And so, yeah, I think it's really exciting.
It is. It is. I love this field. So tell me then, you're a vascular interventional radiologist treating a condition for shoulder pain. What exactly is frozen shoulder for those that aren't sure?
Yeah, so, it really is a good question in the sense that we still don't really understand it all that well. We can kind of describe what it is, right? So the shoulder, it's definitely one of the coolest joints in the whole body. It's incredibly flexible, but it's basically at the end of the day, it's just a ball in a socket. And the top of your arm bone is the ball, and then the shoulder is the socket that it goes into. And in between that, there's a fibrous tissue that kind of helps hold everything together, but also to maintain that flexibility of your arm, the fact that when it works normally, you can move it around 360 degrees, that fibrous tissue has to be also very flexible and kind of spongy, so it's full of fluid. So what frozen shoulder is through a condition that we don't really understand very well. It's a condition where that fibrous tissue gets really hard and gets what we call adhesion. So we call this adhesive capsulitis. That fibrous tissue, we call it the capsule. It's kind of a little cap on top of the arm bone. And it could get fibrotic, which means kind of hardened and scarred. And then what happens is the wall in the socket can kind of get stuck to the socket and not move
It's
around
frozen.
very well.
Right.
It's basically frozen. Yeah. So what really distinguishes frozen shoulder from other shoulder conditions is that it's not just pain, it's that the patient literally cannot move their arm, even if they wanted to. And even more interestingly, even if somebody else tries to move it for them, it's like literally stuck. So it's actually frozen. And that's basically what frozen shoulder is. So we don't necessarily understand why it happens to certain people, but it is something that's quite common. And we know a lot about the patients that do have it.
Yeah, it sounds terrible. Is it something like, are there symptoms to look for before it happens, or do you just wake up one day and you can't move your arm? Like, what should people expect?
Yeah, so basically, frozen shoulder tends to affect people that are mostly middle aged. So typically from the ages like 40 to 60s, most commonly somewhere in their 50s. That could help you distinguish it from a lot of other conditions that might look similar. Basically, if the patient's under 40, they probably don't have frozen shoulder because they're going to be more likely too young for it. If they're over the age of 70, then it's likely just a rotator cuff tear or something of that nature. But in that kind of middle age group, there are people that, for either no known reason or sometimes following an injury, like maybe a surgery or a trauma or a rotator cuff tear, they can start to get this frozen shoulder condition. The best way to describe it is it has three phases. So the first phase is the freezing phase. And that's typically when it first starts, it's extremely painful. And people can have very debilitating night pain. And the shoulder mobility is starting to become limited, but it's really mostly pain that is affecting them. This phase typically lasts anywhere from like 5 months up to a year. The next phase is called the frozen phase. So now that shoulder is actually frozen. The pain is less intense and severe, but now the frozen part of it is at its peak and the patient has severe limitations of their mobility. So something as simple as lifting your arm up or above your head, or even trying the back scratch test, one arm will be severely limited compared to the other arm. And this can last for a very long time. And then finally, there's a third phase, which is called the thawing phase, where now the frozen shoulder is starting to kind of thaw out. That fibrotic tissue starts to kind of break down. And that can last up to a year as well. And then the mobility and the pain start to resolve. And then a lot of patients will get better. But there's a large subset of patients that won't. They'll just stay with this frozen shoulder condition long term. And that's kind of just how this disease tends to play out for a lot of people. So because it's such a long lasting condition that sometimes will go away on its own and sometimes not,
Mhm.
it's a room where a patient need a lot of help and where some of our procedures can help them.
Yeah, we do a lot of direct to patient marketing for frozen shoulder embolization. And when the calls come in and we speak with patients, some people have been dealing with it for years.
Right.
Yeah. So
Yeah.
you're saying even through those two phases, the freezing,
Three phases.
the,
Yeah. Three phases. Yes.
right, the thawing, they
Mhm.
might never
Yeah.
even get to the thawing part, right?
Well, it could last indefinitely for some people, and there are some people that really never come out of it. But even under best case scenarios, you're looking at 2 to 3 years for this to go away on its own. And it's such a poorly understood condition, and the treatments are such variable response that we're not even sure if most of the common treatments work at all. It's
Yeah,
hard to
what are
say.
those? Let's go ahead and touch base on those if we can. Like what are common treatments? And then we'll get to embolizations to the good stuff.
Yeah, of course, of course. Yeah, look, typically, if you have a shoulder problem, most people are going to probably go see their doctor or an orthopedic specialist, and you're going to do the basics. You're going to take NSAID medications, things like Tylenol, Aleve, ibuprofen. You're going to lay off things that aggravate it, maybe not play pickleball or lay off of certain activities at work, etc. Take ibuprofen, Aleve, Tylenol, those kind of things. And then there's physical therapy where they try to help strengthen the muscles around the shoulder and really work on that mobility, which would likely be severely limited. Once people progress past that point, now you start looking at certain types of procedures. The lowest hanging fruit or office based procedures can be something as simple as just a steroid injection, where somebody goes in there and injects steroids into the joint. Tend to have limited effect. For most cases, they work in a short term basis, and often after that, it's contraindicated to repeat this procedure too many times because it could actually have long-term detriment to the joint. There's also what we call hydrodilation, where you can do image-guided injection of fluid into that capsule and try to inject fluid in there and make it expand it, make it bigger, create a little bit more room in there. And then finally, there are these surgical procedures where under anesthesia, they could literally just move that arm around and break up all that tissue. Be extremely painful, so the patient has to be under general anesthesia. And, a fairly traumatic procedure. There have been cases where you could even have a fracture of the bone or something like that, or tear something while you're doing that. And then finally, there's surgical release of that capsule where they can get in there and actually just cut part of the capsule to release it. The issue with these procedures is they've been around a long time. There hasn't been a lot of studies on it that really show whether they work, what works best. And a lot of the recent studies and data show that it's not clear any of them work. These are physical therapy or any of these surgical procedures, and that it's not clear they're even better than just simple watchful waiting. In fact, at the American Academy of Orthopedic Surgeons in 2024, data was reported showing that basically the surgeries are no better, or physical therapy is no better than watchful waiting, or just waiting around for a year to see what happens. And that surgical procedures are not really much better than physical therapy. So by definition, it shows that all of the available standard procedures may not work very well. And so what ends up happening in a lot of these patients is about 30% of them are going to end up with just long-term significant symptoms. Some of them have debilitating night pain, which ruins their quality of life. A lot of them have to go on disability because they cannot work. And just even basic functions like brushing their teeth or shaking somebody's hand, they
Yeah.
can't do these activities.
Two things. So another physician told me that sometimes physical therapy can actually make it worse too. Like the doctors think they're doing the right thing by saying, hey, you should go to
Mhm.
physical therapy. But in fact, that can inflame everything and make it hurt even more.
Well, it's possible, especially if like in the acute inflamed state, maybe you wouldn't really want to emphasize that part of it because it's going to be really aggravated, really revved up. But
Yeah.
I think more importantly than that, what recent data is showing is that the physical therapy is just not likely to speed up the process. And that patients that appear to get better after physical therapy are really just getting better because the disease is just running its course and it's
Yeah.
just going to get better eventually anyway. It's just that most people I know would rather not have to wait 1 to 3 years until it
Yeah.
gets
Who
better on
wants
its
to deal
own.
with it for months and months and years?
Yeah, I tell you what, I wouldn't be able to do my job with a frozen shoulder. So
Right. Yeah.
I don't
And
think most people
you
would
talked
agree with that
about
plan.
the pain at night, and what affects people is the lack of sleep, right? Not just the pain, but you
Hmm.
can't sleep. And how do you function? Like I'm kind of an old lady. I need my 8, 9 hours straight to get through the day. If I don't get my hours of
Absolutely.
sleep, I'm useless.
Yeah, absolutely. No, there have been studies shown that patients who are suffering this nighttime pain, and some patients, it's every single night, up to 90% of patients in that acute phase, it leads to poor job function, depression, and even like relationship issues and things of that nature. It's extremely debilitating because, yes, you're right. They cannot sleep. They cannot find a comfortable position. That's one of the telltale signs of frozen shoulder and in that acute stage.
Yeah, it really stinks. Okay, so tell us, interventional radiology, what is this treatment and how is it better or different than what you just explained?
Of course. Yeah. So what's really different about the interventional radiology approach to this treatment, it is a targeted therapy. So one thing with frozen shoulder, which is similar to some of these other MSK procedures that we do, that at the base level of the pathology, what is actually wrong? We may not understand what causes it, but what we can see in a lot of these cases, whether it's in the knee or the foot or the shoulder, is that people tend to have growth of inflammatory tissue and what we call unmyelinated nerve fibers which are basically nerves that have no business being there and they just hurt really bad. And they're created by synovitis, which is inflammation of the synovial tissue that's there to lubricate the joint. And these are fed by little tiny vessels. We call this neovascularity, or we like to call it the blush, because it looks like what we call a tumor blush. Whenever patients have cancer, they have a lot of little vessels there that feed the tumor. And it kind of resembles that. A really innovative doctor from Japan named Dr. Yuji Okuna, about over 10 years ago now, described treating this pathology. He just kind of looked at the research and figured what would happen if we went in there and actually targeted these little vessels. And what ended up happening is that, amazingly, in the vast majority of patients, when you kill off these abnormal vessels, it tends to kill off that inflammatory tissue that should not be there, and also these unmyelinated nerve fibers that also should not be there. And it actually leads to reduction of pain, reduction of inflammation, tends to have very quick results. And it's one of the few things we know of that is directly targeting pathology. Everything else is kind of indirect treatments. You can do physical therapy and manipulate the shoulder, but you're not really targeting that fibrotic tissue. You can inject steroids, it just reduces inflammation, but again, you're not really targeting the pathology, and same with surgical approaches. So what's really neat about the IR approach is that it's specific, it's targeted, it's image guided, and it's actually directly treating the cause of the pathology. And that's really unique. And these procedures are safe, they're quick, and they're convenient. So I think it's really exciting.
Yeah, it's outpatient, right? Tell us, like, what if someone came into your lab or your office today and had it done? Like, how quick? What is it like?
Yeah, so basic procedure. Let's say that they're the right patient, they've had the right workup, they've tried these other measures that didn't work, and we know that they have a frozen shoulder, and now it's time to do the procedure. So we use a radial artery access. So that's an artery in the wrist. What's really nice about our practice is that we've been using the radial artery access for a long time now, because it's a very small artery, it's very safe for access, minimal risk of bleeding and other complications. And it's a direct shot to the shoulder. You know, your wrist is just a straight shot right up to the shoulder. So it's a really something that we are used to doing in our practice. It's very quick and convenient. So when we do this procedure under local anesthesia, where we numb the wrist, and also just under a little bit of sedation. So the patient will get an IV and just a little bit of medication, like they're having dental work or colonoscopy, just to make them comfortable. But it's actually optional, because it doesn't really hurt to do the procedure very much at all. And then you put a little device in there that we call a catheter. It's just a long, skinny tube that helps us aim where we want to get to in the shoulder. And then we take some pictures, and then we target these arteries that we're going to treat. On average, you're going to treat anywhere from 1 to 4 arteries around the shoulder joint. And what we do is we take pictures and inject some contrast to look, and we're looking for that abnormal tumor blush. And if we see it, then we target it, and we inject a little medication that we call an embolic that blocks these little tiny vessels. What's neat about the medication that we use, it only blocks these tiny abnormal vessels. If it were to get into any other vessel, it should reopen up within a few minutes, because it's a temporary embolic. But we're able to really keep it on track by using targeted catheters and imaging to go where we want and target the abnormal pathology that we want to target. The entire procedure on average is going to take about 60 to 70 minutes. And at the patient, when they wake up from the procedure, they'll have a little wristband on, and typically they could go home anywhere from 1 to 2 hours later, as long as they're doing well.
Wow.
After that, the recovery is really minimal. I would just caution, just due to the puncture site, take it easy for a day or so. But I would allow patients to go back to physical therapy within 3 days after that, and go right back to doing all the treatments that they want to do, to try to just maximize the efforts and get the shoulder feeling better sooner than later.
And how quickly do most patients feel the relief? Like, when do they get that range of motion back in their shoulder?
Yeah, so the results from all the studies are a little bit variable. Some of them report relief within as quick as a week. Most of them, it's about a month, 1 to 3 months, when they notice that significant relief. And at 1 month, it's a significant improvement, and then at 3 months, even more. So you definitely should expect significant improvement within 1 to 3 months, which is, obviously much, much better than having to just wait the disease out, or potentially recovering from a surgery that could, have to have your arm immobilized for often 6 weeks or even longer potentially. So pretty quick results, and much quicker than physical therapy, and just waiting for the disease to run its course.
That's great. So if they're not sure they have frozen shoulder, where do they start? PCP, ortho, they come to you. Can you kind of help guide somebody that direction?
So typically, by the time patients come to us, they've already kind of been through the pipeline frequently. They've, tried the other measures, maybe did not work, et cetera. But we are trying to reach patients directly through patient outreach, education, social media, et cetera. So if a patient is thinking, do I have frozen shoulder on their own, and they haven't been seen, I would encourage them, go to your primary care doctor, go to your orthopedic surgeon if you have one. But things that resemble frozen shoulder, if you're in that right age, right? If you're kind of like somewhere in your 40s to 60s, if you are having that night pain, and then also one of your shoulders is severely limited in motion compared to the other. So things you can do is, can you abduct your shoulder on both sides equally? The back scratch test, sometimes when a patient has the frozen shoulder, one arm can only reach like their gluteal area, whereas the other arm can reach all the way up the scapula. Or even just forward elevation, how high can you go? And see, is the motion actually limited? One. And then the second thing that's really helps us distinguish whether it's frozen shoulder versus something else. Typically, when patients have an injury, a rotator cuff, etc., it's pain that stops them. They can actually move their arm, but it just like it hurts, so they stop themselves. But somebody else can move it for them. That's called passive motion. So what we would do in the clinic to distinguish whether it's frozen shoulder versus something else is the doctor or the provider will actually move the arm around and see, can I move it? And frozen shoulder is actually a mechanical obstruction. So the patient cannot move their arm and you can't move it for them. That's that passive motion that really, I think, distinguishes frozen shoulder from other entities. So if you are at home wondering, do I have frozen shoulder? I would recommend go be evaluated. But I suppose if you had somebody try to move it for you and they cannot move it because it just won't go anywhere, that would be something indicative of frozen shoulder. But obviously, I'd recommend that you have a healthcare provider try to do that examination for you.
Yeah. I mean, just what you're saying, a mechanical abstraction sounds to me like you don't need an X-ray or MRI to diagnose that. Literally, your arm doesn't move or someone else can't even move it, right?
Yeah, yeah. We don't really need to rely on imaging to make this diagnosis. It's really more of a clinical diagnosis. That being said, though, it's often a good idea just to get an X-ray, only because an X-ray, just to rule out, is there a fracture, a dislocation, or something like that. So at the very basic, if a patient of ours has no imaging whatsoever, we might order an X-ray. And then again, most patients who do come to see us have already been down the pathway and they may have other imaging we could refer to. But other than an X-ray, you really don't need any other imaging. There's not really going to be a lot of pathology on imaging, right? That's the weird thing about it. It's just stiffening of that capsule in that shoulder. So you're not necessarily going to see a tear or a fracture or anything that dramatic. And that's one of the things that's really interesting about it.
Is there anything else you want to share before we close out and you share about this condition?
About frozen shoulder, I would just share that if anybody out there has frozen shoulder and you've had it for a while and has not responded, we understand how difficult of a condition it is. And there is a new treatment modality that's available that may be helpful. And so there's hope for some of these patients. I met a gentleman recently that he was a new patient with frozen shoulder. He had already had surgery and tried everything in his power, and his arm has been like this for several years. And the poor gentleman wasn't able to shake my hand with his right hand because he couldn't even do that. He had to shake my hand left-handed, and he's doing pretty much everything with his left hand. And it's really just heart-wrenching to see somebody in that condition. And I'm just very happy that we have something that might be able to help these patients and just give them some hope, and also at least change their time frame. Just be like, you don't just have to wait for potentially years for this to just get better on its own. There is a new option out there that the results are shown to be as good or better than surgery, and without the recovery, and could get relief significantly quicker.
The story you just shared about shaking the gentleman's hand, I interviewed a lady who had her shoulder done, and I kind of asked her, like, how did you get to the clinic in the first place? And she said she was actually going there for a genicular artery. She had knee pain. And when she walked in the room, the doctor reached his hand out to shake her hand, and she couldn't do it.
Oh,
And
wow.
he said, well, what's going on? She goes, well, I'm here to see you for my knee. And he goes, no, no, no. What's going on with your arm? How come you can't shake my hand? She's like, oh, it doesn't move. I've been dealing with it for years. It's fine. Can you help me with my knee? And he was like, well, let's talk about your shoulder. And he did the embolization on her shoulder and her knee. So she got, both of them done. But she said afterwards, I said, what's been the biggest thing for you since you had it done? She said, and her son was with her, and I'll never forget this. She said, I can go out to eat now.
Wow.
And I said, you can go out to eat.
Yeah.
I was really confused, right? I was like, what do you mean? She said, I couldn't go and eat in public because I would have to bend over and shovel the food into my mouth because she couldn't even lift a fork to her mouth.
Yeah.
Like, I have
That's
chills telling that story. You
Yeah,
don't
yeah,
think about the
absolutely.
everyday basic things like feeding yourself, brushing your teeth that we all take for granted because we just get to do it all the time. And I was like, I literally was like tears in the eyes, like, wow, life changing,
Yeah,
And she went in
absolutely.
for her knee. So
Yeah.
it's really the limitations that it has for people and the things they miss out on. I think if someone's considering treatment, those are the things I think they're going to look forward to, is like you said, washing your hair, brushing your teeth. The fun stuff is like
Yeah.
playing golf and doing all that sort of things again, but the everyday things.
Yeah. Or how about just doing your job? So this gentleman, he's not able to work in that condition, and many of these patients end up on disability. I wouldn't be able to do my job if I had a frozen shoulder, and many people would not as well.
Yeah.
And yeah, a lot of these MSK conditions are very common. It could affect your foot, your knee. But like you said, if it's your knee, it's obviously going to really impact your life, and you may have to rely on a cane or limp around, but you can do basic things. But if you don't have both of your arms functioning, you can't even go out to eat or type on a computer or do basic job functions. Yes, it can severely impact your life. For that reason, I'm just really happy that at least there's another option out there that has extremely promising results.
Yeah. And it sounds like you guys are doing a great job down there in Houston treating these conditions. How do people in your area learn more about you, your practice, and maybe even get an evaluation?
Of course, yeah. So we're Texas Endovascular Associates. So I think we have a pretty good website that has profiles of all the procedures we offer and our providers as well. So that'd be a good place to start, provide some education about the procedure and everything that we offer. And yeah, we're trying to do some patient outreach as well, get the word out. And you could also talk to your primary care provider, who they refer us a lot of patients as well. So I think that would be a good place to start.
Good. And for everyone out there, their website's super easy, texaseva.com. They do have lots and lots of resources, patient testimonials that you guys have actually done these procedures on. And then all the physician bios are on there too. So I suggest checking it out. Thanks, Dr. Valenson, so much for being here with us and spreading awareness about MSK treatments. And, I'm super excited about all the things that are coming, right? You'd mentioned you could do it in the foot, the elbow, your knee. I mean, there's so many things coming out there that I think the more and more the interventional radiology gets to play with their toys, their wires, and their catheters, the more people you guys are going to be able to help.
First off, it's been a real privilege and a pleasure to be here. So thank you so much for having me. And yeah, the interesting thing about this MSK field is that for whatever reason, whether it's in the hip, the knee, the Achilles, the foot, the plantar fascia, the pathology seems to be very similar, where you have these abnormal vessels growing. And so the treatment is very similar. So it's just literally about getting to a different part of the body, but performing kind of a very similar procedure that we're already used to doing in other parts of the body. So it does kind of apply to different MSK areas, and these are extremely common. And some people have multiple MSK issues at the same time. So yeah, I think this field is just going to hopefully keep growing.
Yeah, me too. All right. Well, thanks so much for being here with me. I appreciate you.
All right. Thank you so much.